All right. Good afternoon, everyone. Thanks for joining us for today's webinar offered to you by the Center for Financial Security and Retirement and Disability Research Center at the University of Wisconsin-Madison. Just a few notes before we get started. Reminder, this webinar is being recorded and the recording and slides will be posted on the CFS, Center for Financial Security website later this week. That'll be at cfs.wisc.edu. And let's go ahead and move into the content. So, my name is Jonathan Ferguson. I'm a financial capability specialist at CFS, and I'm going to be facilitating today's webinar. So we have a great webinar lined up for you here today with a research presentation and overview that includes background, methods, and findings on the title of our webinar today, Health Insurance and Financial Security. You're going to learn all about that. We'll also have some context in the lens of policy and practice today. With a few discussants who you'll meet in just a little bit. And then we'll also have, as time allows, a Q&A portion of the webinar after the presentation. So you'll see a Q&A box in your screen there. So feel free to drop your questions there and we'll collect those throughout and get to as many as we can during the Q&A portion. And then we'll move on to the closing. All right, so I'm going to start by introducing our speakers today. We've got two researchers and a policy discussant and a practice discussant. Our first researcher that I'm going to introduce is Dr. Katie Fitzpatrick. Katie is an associate professor and director of the Master of Public Policy program at the Joseph R. Biden Jr. School of Public Policy and Administration at the University of Delaware. Prior to coming to the Biden School, she taught at Seattle University and was an economist in the Economic Research Service at the USDA. Her research centers on financial decision-making, how the use of financial services affect economic well-being, how participation in government assistance programs affects economic behavior, and how families make decisions about spending and building assets. She holds a BA in public policy from Stanford University, an MPP from Georgetown University, and a PhD in economics from Syracuse. Our next researcher is Dr. Keisha Solomon. Keisha is a research scientist in the Department of Economics at Howard University. She began this position in August 2022 after completing postdoctoral training at the Johns Hopkins Bloomberg School of Public Health and doctoral studies at Temple University. Dr. Solomon is an applied microeconomist with research areas of interest that lie at the intersection of health and public economics, policy analysis, applied econometrics, and poverty and inequality studies. She has published several peer-reviewed studies within the fields of health economics and health policy. Our policy discussant today is Dr. Kabir Dasgupta. Kabir is a senior economist at the Division of Consumer and Community Affairs at the Federal Reserve Board, where his responsibilities include policy-related work for his division and working on independent research. Kabir graduated with his PhD in economics from Temple University. Prior to joining the board, Kabir was a senior research fellow at Auckland University of Technology in New Zealand. His research involves applied microeconomic analysis in the areas of health, labor, and public policy. He has published in various peer-reviewed academic journals, including Health Economics, Labor Economics, Journal of Health Economics, among others. And last and certainly not least is our practice discussant, Caroline Gomez-Tom. Caroline is the Enrollment Network and Accessibility Manager at Covering Wisconsin, where she works to improve access to health literacy and affordable health insurance coverage. She serves on the boards of the University of Wisconsin-Madison School of Social Work, Board of Visitors, the Children's Health Alliance of Wisconsin, and Kids Forward. For 2022-23, she is elected president of the City of Milwaukee Board of Health. She earned her master's degree in social work from the University of Wisconsin-Madison with an emphasis in social policy. And with that, I will turn things over to Dr. Solomon and Dr. Fitzpatrick.
Hi, good afternoon, everyone. I am Keisha Solomon, and today I will begin the presentation on a project that I'm working with Dr. Fitzpatrick on, and this project examines the impact of public health insurance policies on health insurance coverage and financial security. So I am going to summarize the background and conceptual framework, and then Dr. Fitzpatrick will summarize the results, data, and policy implications. So before I start to summarize the background, I would first like to state a disclaimer, and that is the opinions and conclusions expressed are solely those of the authors and do not represent the opinions or policy of SSA or any government agency. So in this study, we examine the implementation of ACA Medicaid expansions. First, we examine how these expansions affect health insurance coverage and their impact on health. Given that out-of-pocket costs can be high for individuals without health insurance coverage and ultimately affect financial security, we also examine how Medicaid expansion policies affect financial security. So next, I'm going to give an overview of the background. So it's important to examine policies that can reduce medical bills for a number of reasons. First, medical bills, which are generally higher for individuals without health insurance coverage and individuals who are underinsured, is a key source of financial hardship for many Americans. Specifically, for example, there is evidence that about 2 in 5 non-elderly adults struggle with medical bills or debt, and more than half of all bankruptcies filed in the US are due to medical debt. The figure on the right shows that since 2014, medical debt is the largest debt in collections in the US. Another reason to examine policies that can affect medical bills or expenses is because medical expenses and debt affect healthcare utilization. For example, there is evidence that there is a negative association between medical debt and healthcare use. Further, in 2021, about 9% of non-elderly adults delayed or went without healthcare because of its cost. And we know that reductions in needed healthcare utilization can lead to worsening of an individual's health, can also lead to reductions in human capital accumulation, as well as ultimately adversely affect the US labor force and development of the economy. How does health insurance affect the outcomes measured? There is evidence that health insurance improves healthcare access, as well as improves household finances and creditworthiness. Within this study, the health insurance that we focus on is Medicaid. One of the reasons we focus on Medicaid is because individuals from low-income households are more likely to experience financial hardship than individuals from higher income households. And we know that individuals from low-income households are also more likely to be eligible for Medicaid coverage. Further, given Medicaid's comprehensive coverage, that is in terms of premiums and low cost, Medicaid coverage also results in lower out-of-pocket costs for individuals on average, and this should result in lower financial hardship. While there is evidence that Medicaid coverage improves health of non-elderly American adults. In this study, we focus on the near retirement population because the near retirement population, in comparison to younger adults, is more likely to have chronic conditions, which could result in higher medical bills and ultimately higher financial insecurity. So next, I'll briefly provide some information on the Medicaid program, specifically discussing the difference in the state Medicaid programs before and after the implementation of the Affordable Care Act, which is also known as ACA, in 2014. So before the implementation of the ACA, state Medicaid programs generally covered pregnant women and children from low-income households. There was also coverage for SSI recipients and limited coverage for parents, limited coverage of parents. However, in general, a majority of the states did not provide any coverage for childless adults because there was no federal requirement for coverage to be provided to this population. In 2014, when the ACA was implemented, states were encouraged to expand the eligibility rules of their Medicaid programs. Specifically, they were encouraged to expand the eligibility to provide coverage for everyone, regardless of whether they had a child or not, at or below 138% of the federal poverty line. Because of this new rule, the ACA Medicaid expansions primarily affected non-elderly childless adults who were previously not eligible for Medicaid coverage. And this graph shows the variation in Medicaid expansion from 2014, that is when the ACA was implemented, to 2022. The figure on the left shows that in 2014, when the ACA was implemented, 27 states, including DC, decided to expand their Medicaid eligibility rules. And by January 2022, 39 states decided to expand their Medicaid eligibility rules. And I should mention that since the expansion of Medicaid, there was an increase in the number of enrollees by about 15 million Americans. So what has been the impact of the Medicaid expansion since its implementation? There are a number of studies that have examined the impact of the ACA Medicaid expansions. And in general, these studies find that the expansions led to reductions in the amount of uninsured Americans, increases in access to and use of healthcare, as well as had positive spillover impact on employment and financial security measures. So in this study, our conceptual framework is that Medicaid expansions could improve access to healthcare, which a number of studies find, and this would ultimately improve health, as a number of studies find. Second, we hypothesize that the expansions have ambiguous effects on out-of-pocket costs. Specifically, the expansions can result in lower out-of-pocket costs for individuals who were already using healthcare services, even when they did not have health insurance. But the expansions could increase out-of-pocket costs for those who did not receive any healthcare services while they were uninsured. In terms of financial hardship, we hypothesize that the expansions will reduce financial hardship, all else equal, because the expansions would lead to improvements in health, which would ultimately allow individuals to work longer, as well as ultimately increase their income and savings. Therefore, our research question was what is the impact of ACA Medicaid expansions on medical bills, medical debt, financial hardship, and retirement savings among the near retirement population. We examine the impact of the expansions over time since the implementation of these expansions, as well as the impact of the expansions during the pandemic. The reason why we examined the impact of the expansions during the pandemic is because the pandemic worsened financial hardship among many Americans. Specifically, the impacts were greater for individuals from historically disadvantaged populations and individuals with low socioeconomic status, as well as those who worked within the service industry. And one point to note is that even before the pandemic, about 40% of American adults noted that they would have difficulty covering a hypothetical unexpected expense of $400 US. So next, I'll now hand it over to Katie for her to discuss the data used in this research project.
Okay, thank you. So we are going to use two different sources of data. The first source of data we will be using for looking at households over time is the Survey of Household Economics and Decision-Making, or SHED. And the SHED measures the economic well-being and financial lives of U.S. households. It's run by the Federal Reserve and started in 2013. So we're going to follow households that have similar characteristics from 2013 to 2019. So because our focus is on the near retirement, we're going to focus on adults 45 to 64. So if we look at our sample, we see our samples obviously in that age range, and it's at the slightly higher end of that age range, consistent with demographic trends. Additionally, we have a lot of childless households in our sample, right? Just due to kind of family formation patterns. We have a lot of married households, but few households with children. In terms of education characteristics, about 2/3 of the sample has at least some college education, and more than 2/3 are employed. So we're going to use this sample to compare outcomes of individuals based on the state they live in and their state Medicaid decisions. So, right, we're going to look 2013 to 2019. The first result we have is that we find significant increases in health insurance coverage from the Medicaid expansion. And our sample estimates are in the range of the literature looking at this age group. So we found about a 4 to 8 percentage point increase among this sample. And the graph on the right shows how the Medicaid was expanded in the state and the resulting characteristics. Right, so we've seen really robust increases in Medicaid coverage. Interestingly, effects on Medicaid coverage is greater than effects for any health insurance coverage, which suggests some crowd out of health insurance. So some people move from private health insurance to public health insurance. Our next result is looking at out-of-pocket medical expenses. So we don't find strong evidence that there was big improvements in out-of-pocket medical expenses. Right? We see instead some suggestive evidence. So we first look at households that have report no unexpected out-of-pocket medical expenses, and we see suggestive evidence that there's some increases, and we see some declines in estimates of people that report $500 or more in unexpected out-of-pocket expenses. So while Medicaid's very comprehensive coverage with low cost sharing and low premiums, right, we would expect that we'd find really robust evidence here. And we do not find that, and that may be because of different state Medicaid rules about cost sharing. Our next result is looking at financial hardship. So we look at reports of struggling financially, inability to pay bills, and cutting any health care due to cost, right? And again, we don't find really strong evidence of improvements in financial hardship, right? So there are some reports of struggling financially, but lower reports of not an inability to pay bills, right? So this is kind of mixed evidence here. And kind of most surprisingly is that we see increases for individuals in states that expanded Medicaid in reports of cutting any health care due to costs. Right, so this was a little bit surprising, and again suggests perhaps there's we need to look more at specific state Medicaid rules. We also find relatively little change in medical debt, credit card debt, and confidence in securing credit. Remember that medical bills are a big contributor to financial fragility and debt. They're the largest source of debt and collections, so we would expect if there was, big changes in out-of-pocket medical spending, that you might see reductions in medical debt. We see some declines in medical debt, some reductions in unpaid credit card debt, and some reductions in other reports of credit card debt, but the evidence is not really robust, right? We don't have strong, significant estimates that these are improving in the ways we would think. We also see no change in kind of confidence of securing credit if they needed to. Our next result is looking at savings. So we look at savings in two ways. First, we look at emergency savings, which doesn't have a formal definition in the literature. So we look at several different measures. First, this measure of ability to cover $400 of unexpected expenses in cash or its equivalent, and of reports of covering 3 months of expenses, which is a big difference than $400, and reports of saving for emergencies. We see declines in all of these measures. We also look at retirement savings. Again, we don't see big improvements in retirement savings. There's increases in reports of no retirement sources, very little change in total savings for retirement. And if we just look at above or below $50,000, and some increases in borrowing for retirement savings, right? So overall, if we don't see changes in financial hardship might be continuing. Perhaps it's not surprising that we don't see this change in savings. People are not improving their savings for emergencies or their savings for retirement. The next result we look at is labor supply. So we don't see, again, big changes in retirement or claiming a disability, right? So this idea of job lock, where people are unable to retire because they don't have access to health insurance, we don't see that Medicaid is changing that. We also don't see changes in reporting disabilities, and both of these are in line with the literature in this area. But unlike some of the other literature, we don't see changes in reports of applying for any Social Security administered benefits, whether that's retirement or disability or SSI. So we don't see changes in benefit claiming with Medicaid expansion. Next, I'll take you through the results looking at the pandemic period, and we're going to use two different sources of data here. So the first source of data we are going to use is the SHED. So the SHED in April 2020 and July 2020, they took the 2019 sample and re-interviewed them to understand their experiences during COVID. There is also a special supplemental data set created by the census in collaboration with a lot of federal agencies that continues today, and that's the Census Household Pulse Survey. And the Pulse Survey is trying to measure household experiences during COVID. And so collection began in April 23, 2020, and it continues today. We're going to use the same sample criteria as before, so looking at households with adults age 45 to 64, and we're going to merge on both unemployment insurance claims as well as COVID severity to really capture what people are experiencing on the ground. And we're going to measure Medicaid expansion as whether or not the state expanded Medicaid by 2020. Right? So perhaps not surprisingly, we see that states that expanded Medicaid during the pandemic, they had higher rates of both any health insurance as well as much higher rates of Medicaid coverage, right? So more people in these states had insurance coverage. The next result we're going to look at is looking at financial hardship. So the graph on the left is from the Household Pulse Survey. The graph on the right is from the SHED supplements. So here we see improvements in financial hardship among people in states that expanded Medicaid. So they have less difficulty in paying their usual household expenses and slightly lower rates of food insufficiency. So they seem to be doing better. If we look at households in the Pulse, right, they also report less difficulty in kind of financial struggles, as well as less inability to pay bills. So again, people look like they're financially better off in states that expanded Medicaid during the Pulse or during the pandemic. We also look at emergency savings, and we're only going to use the SHED for this. The Pulse did not ask about it, but we see that respondents in the SHED report more ability to cover unexpected expenses, and they're just looking at an unexpected $400 expense. So again, not a lot of unexpected, not high unexpected expenses, but again, they do look better off, consistent with kind of less financial hardship in these states. Next, we look at whether households were applying for any Social Security administered benefit. The question actually asks about Social Security, retirement, disability, SSI, or Medicare, but because many of these households are ineligible for Medicare because they're 64 or younger, we're really thinking this as a measure of Social Security administered benefit claiming. And again, this is from the Pulse. We see basically no difference. So individuals in these states were no more likely to apply for Social Security administered benefits than people in states that did not expand Medicaid. Okay. So just to summarize our finding, right, we find that health insurance may be particularly important for households near retirement, and we see larger increases in health insurance coverage, especially Medicaid coverage, and this continues through the pandemic. If we look at our households over time, so during the 2013 to 2019 period, we find basically suggestive but inconclusive evidence about out-of-pocket spending. We surprisingly find reductions in savings, which is not what we expected. We find very little change in debt. We find possibly increases in financial hardship and no changes in labor supply. Right? So that's our longitudinal look, our look over time. If we look at just during the pandemic, it tells a very different story. We find less financial hardship, more emergency savings, but no difference in claiming Social Security among individuals in states that expanded Medicaid versus not. Right? So we might be picking up something about states that chose to expand Medicaid. Okay. So thank you very much. We are going to now turn it over to discuss the policy implications.
Thank you, Katie and Keisha. Hi, everyone. My name is Kabir, and it is my pleasure to discuss the very interesting research that was presented by Katie and Keisha just now, particularly because I work at a division of the Federal Reserve Board that conducts and administers the Survey of Household Economics and Decision-Making, or the SHED in short, which is used to track the financial well-being of US households. Since time is of essence, let's dive directly into my discussion. Sort of briefly summarize my understanding of Katie and Keisha's research. They asked whether access to Medicaid improve financial well-being of households headed by near-retirement individuals, particularly those who are aged 35 to 64. And for their analysis, they look into two data sets. One is the SHED, obviously, and the other one is Census's Household Pulse Survey for the pandemic, for the analysis during the pandemic. And focusing on the pre-pandemic period, the results indicate that while ACA's Medicaid expansion led to an increase in Medicaid coverage among households headed by near-retirement adults, there were no significant differences in financial indicators between households belonging to expansion and those belonging to the non-expansion states. However, during the pandemic, based on descriptive analysis, the households in non-expansion states appear to be more likely to face financial difficulties and are more likely to have financial struggles in meeting their expenses compared to those in expansion states. So I'm going to talk first about their motivation and the policy implications. So first, I read this paper with great interest, as I believe that near-retirement older individuals are an understudied group. As such, I think that this research adds valuable insights into a policy-relevant area. This is because compared to younger population, older individuals who are approaching their retirement are usually at a greater risk of health-based morbidity, and therefore more likely to have a higher health cost. Given this background, lack of insurance can increase economic burden in various ways. I can think of two. First of all, lack of insurance could lead to non-utilization of healthcare services to avoid out-of-pocket expenses and thereby increase future health risk, which may have a negative impact on their labor market activities and economic well-being in future as well. Alternatively, if uninsured or underinsured individuals choose to incur out-of-pocket health expenses to cover their healthcare needs, they might try to cover their health costs by trying to increase their labor supply, thereby adding further pressure on their already deteriorating health. With all these health risks at play, the means-tested programs such as the Medicaid can indeed provide some much-needed financial relief to economically vulnerable populations. However, at the same time, having insurance or not having one could prompt various health or non-health behaviors. As such, from the policy relevance perspective, the ACA's Medicaid expansion could also lead to various individual-specific heterogeneities that could provide the underlying mechanisms behind the key research findings in the study, especially the lack of significant differences in the financial well-being outcomes during the pre-pandemic period. To that end, I take this opportunity to make some suggestions that the authors can feel free to ignore. First, to motivate the social relevance of the topic, I think the research could benefit further from further exploration of studies in the relevant literature that provide empirical evidence on the impact of the Medicaid program on health insurance coverage especially of near-retirement individuals, thereby indicating whether their empirical estimates are in the range of those estimates that are found in the literature. They do in the paper by comparing their estimate with one of the studies, but I found there are multiple other studies that they could look into for creating a range of the estimates that are found in the literature. And also this could help informing policymakers about the extent to which the ACA's Medicaid expansions could increase coverage for older people. Additionally, the authors can also provide literature-based evidence on healthcare benefits of the Medicaid programs. For example, Katana and their co-authors look at the decrease in cardiovascular morbidity among older people. Next, having a generous health insurance program could also affect people's retirement decisions and thereby bear implications for the opportunity cost of retiring. Adding more into those evidence could also provide further motivation for the policy relevance of the study. Lack of Medicaid for low-income older population could also affect the activities they engage in to cover their out-of-pocket expenses. For example, gig work, increasing labor supply, and availing alternative grade access, and so on. So from the policy implication perspective, it might also be worth including some discussions on how representative of the SHED and the pulse survey samples are. I know there's nationally representative samples, but since there's a state level analysis, so it might be nice to provide some discussions on how representative the SHED and the pulse survey samples are at the state level, especially the states that are evaluated in the study. For some of these suggestions to promote the policy relevance of the topic, I make some empirical recommendations in the next slide. Again, please feel free to ignore if they don't make sense. So first of all, for consistency, the authors could compare the SHED-based result on the health insurance coverage with the Census Bureau's American Community Survey or the Current Population Survey, both of which incorporate a larger population, have state identifiers and detailed information on public and private health insurance coverage. So that can complement the literature-based evidence and the range that they would find in the literature. The authors also mentioned that the new Medicaid expansion are also going to benefit low-income adults with no children. Maybe that's the group of interest that could be motivated further in the study. So it might be worth considering rerunning the analysis for households with no minors as a proxy indicator for adults without any children. But to me, the most interesting result is that the ACA state Medicaid programs led to an increase in health insurance coverage, but there was no effect on financial conditions. And this led me to think about what could be the underlying mechanisms of having state-sponsored health insurance or lack thereof, how they could potentially prompt some health and financial behaviors. For example, to meet out-of-pocket expenses, the households in non-expansion states could choose to engage in gig work, as already mentioned, or take up additional jobs, which can be tested using the SHED or the CPS. And they could also rely on short-term credits like payday loan usage or pawn shop loan usage, and so on. And during the pandemic, especially, people who were in the non-expansion state may not have had much scope to avail these financing sources. So these can be tested, or at least some indicative evidence could be provided using some of the SHED variables. Additionally, households in non-expansion states also may choose to follow a healthy lifestyle and be less likely to engage in risky behaviors to avoid out-of-pocket expenses. And on the other hand, having insurance can prompt an opposite effect. So these again can be reflected in the financial outcomes that they are finding, financial consequences that they're finding in their study. So as a potential source, the health and behavioral disparities in the expansion and the non-expansion states could be tested using the CDC's behavioral risk factor surveillance system data. And given the group of interest is near retirement population, exploring retirement and retirement decisions specifically motivated by health reasons, again, one of those variables are already in the SHED, that could add further insights into the analysis. Next, in the subsample analysis, the authors find negative relationship between Medicaid expansion and overall health insurance coverage for Social Security benefits, benefit recipients, and also for people who have worse health, self-reported health. I found these results quite interesting and thought whether these individuals are already on Medicaid program, while the state level expansion could also at the same time be associated with losing private insurance coverage for some people. And that is why they're finding the negative relationship in overall health insurance coverage. As such, employers' responses could be an important factor to consider, although I don't think it's vital for the study. Some minor points. So in the non-expand, I really appreciate the authors, appreciate the fact that the authors provide detailed summary statistics of the different variables, different characteristics to compare the characteristics between expansion and non-expansion states. But I felt that they could do a little bit more by looking at the summary statistics of the same variables for the pre-policy period, so that could give some indicative evidence whether the difference in the vulnerability, socioeconomic vulnerability across the expansion and non-expansion states are likely a salient feature of these states that we are looking at, or whether they might be potentially an outcome of the Medicaid expansion. And it might also be worth considering adding some summary statistics in the health outcomes between expansion and non-expansion states that could provide some of the insights or some of the mechanisms that I discussed. I also, while reading the paper, I also felt that further context to the discussion of the empirical findings could be helpful. So tying those underlying mechanisms that I suggested, or that could be tested using either the literature or the data, empirical data, and providing anecdotal evidence could substantiate their main findings and could provide some key explanations to the main findings. There could also be some discussions on why they do not find any significant differences across the category eligibility of the SSI recipients. That would be nice to understand if they have any key insights into that relationship. And in some places, although they find statistically insignificant differences between expansion and non-expansion states, I thought some of the specific explanations about the negative relationship could actually lead readers to kind of a different direction from what one could expect from this Medicaid expansion. So maybe to avoid highlighting some of the statistically insignificant effects could be helpful for their way ahead. So that is all for me. Thank you again for a very interesting presentation, and good luck for the way forward. I would now hand over to Caroline.
Thank you, Dr. Kabir. And I don't know if I have access to the presentation. Oh, I do. I see it now, I think. Oh. There we go. Thank you. All right, so I'm Caroline Gomez-Tom with Covering Wisconsin, and I'm going to kind of give a more zeroed in perspective from our experiences here in Wisconsin. So I know that the study looks at overall states that have expanded or not expanded Medicaid. And so I figured by sharing a little bit about Wisconsin and what Wisconsin did, it might also show some insight based on the research that Dr. Fitzpatrick and Dr. Solomon put together for us today. And then also give a little bit of my insights on maybe how the results shook out and how I could see either similarities or differences here in Wisconsin. All right. And I'm not seeing the arrows. Oh, no, I do. Okay. So I'll be going over who we are at Covering Wisconsin, what we do. I'll talk a little bit about Covering Wisconsin's navigators because I think that's an important factor in choosing coverage and helping people choose the right coverage for themselves. Why health insurance is so important, and why is this an issue that along with other different costs in someone's life, why is health insurance such a big component of that? And then we'll go over some basic health insurance options to kind of talk through this group of between 45 and 60-year-old folks that are near retirement, and what are the directions that they might be thinking of going in at the time that they're transitioning from work to maybe minimal work or not working. Oh, okay. Oh, sorry, went too fast. So Covering Wisconsin, we are actually a program out of UW-Madison. We function as a nonprofit that helps people in Wisconsin find and use health coverage. And we really emphasize in not just finding, but using, because we realize that if you don't know what your coverage options entail or what your benefit plans cover, then you're less likely to use them. And I think we've seen some reflections in the study of maybe a cost still incurring for people because they're not familiar with the plan that they have and when they can or cannot use it, or how they can and cannot use it. We also have health insurance navigators. So we receive funding from the Centers for Medicare and Medicaid Services that allows us to help people both with the state's Medicaid program and the health insurance marketplace. And we serve all 72 counties here in Wisconsin. And then additionally, for our community partners and other key stakeholders across Wisconsin, we provide education, outreach, and promotion around enrollment access tools. And so one example that you'll see is on our website. You can go to coveringwi.org/learn, and we have resources that talk through our Medicaid program, Badger Care Plus here in Wisconsin, as well as insurance in general. So what can I do if I can't pay my medical bill? There's a lot of resources that we actually consumer test. So they are looked over for readability, literacy levels. And we just overall want to make sure that the people that are using them, whether it's a community partner helping someone understand their coverage or the person themselves, it's accessible information, because like I said, health insurance is not the end all in good health. We know that it's only a window or a door. And there's so many other factors in someone's life. If you're in the public health world, social determinants of health, what I like to consider foundations of community health, all are played in terms of factors of what will make someone healthy in where they live, work, and play. And health insurance is just a little component to get them to the point of access of care. And these resources are made so that people have more comfortability understanding the tools that they have to maintain their health. And so, as I mentioned, we have the Navigator grant from the Centers for Medicare and Medicaid Services. And so health insurance navigators provide free help so that people can know their options for the plans and financial help that they're eligible for. We can help people sign up for healthcare.gov coverage, which is the health insurance marketplace, as well as Badger Care Plus. And then we also help folks understand their benefits, so that when they need to go in for a procedure, or they need to figure out how much their medication is going to cost, or if they just overall want to understand the different benefits that they have, we can walk through that with them. And our goal is for them to feel empowered to use their care when they need it, because we know that it only becomes more expensive when people wait on care that they need, and preventative care is key to maintaining a healthy life. And so this is just an example. I mean, it is the example of our Navigator program and where we are. So we actually subcontract with key stakeholders across the state so that we're able to serve all across Wisconsin. And we are able to do in-person appointments as well as virtual and over the phone. And so then the question is, as I mentioned, there's all these other factors that impact someone's health, but why is health insurance so important? And it is important, and it's because it helps someone stay healthy and save money. And so it's both financially important as well as important for their health. One of the things that we see the most when people come in to one of our navigators for an appointment, especially if they're coming into us uninsured or with the fear of losing their coverage, is just obvious stress. Sometimes they might be a little frustrated or short even with our navigators, because they might have taken several steps in working with other community partners to get to us, and they're unsure where we're able to help. But it's amazing to see that once we are able to build a rapport with someone and get them the coverage that they're eligible for and that they feel comfortable selecting, you see this peace of mind come from their brain and their shoulders, and you see them relax in front of you. And usually they're very thankful, and usually they come back, and then they come back with friends. And this is one of the ways that we build our network of people that we serve. But the reason that I wanted to emphasize how important health insurance is because I think a lot of folks, as the study shared, will go without healthcare. They'll wait. And that's actually one of the main reasons why certain diseases or health concerns are not caught early on, and why prices of certain services and visits can get so expensive, because when you're trying to treat something that could have been prevented or could have been caught earlier, the costs just skyrocket in our healthcare system. So it's so important for us to connect people to the coverage that they are eligible for, but also, and I think this is a big component of the population that we're talking about, the coverage that makes sense to them. So we'll talk a little more in depth about what those options look like. So one of our how-to sheets that we use pretty much with everyone is this options for you and your family. And here in Wisconsin, we have various options that people can qualify for. But one thing, and associated with this study that I wanted to mention, is that our state did not expand Medicaid, or at least it did not expand Medicaid based on how the ACA had required it initially in the law. So the ACA wanted each state to expand Medicaid up to 138% of the federal poverty level. And so for a single individual, that's around $20,000, at least in current income levels. And for a household of two, because I'm thinking of our retired individual, single individual, or a retired or soon to retire couple, a household of two would be around $27,214 at that 138% FPL level. Well, our state did not expand to that level, but what it did do was something a little different. So originally we had eligibility for children and parents and pregnant women, where children were eligible for Medicaid up to 300% of the federal poverty level, pregnant women as well. And then parents, not all adults, but parents were eligible up to 200% of the federal poverty level. But when the ACA was being implemented in our state, our governor at the time decided not to take federal dollars, but still expand to adults without dependent children, but in doing so, lowered eligibility from 200% of the federal poverty level down to 100% of the federal poverty level, allowing adults without dependent children to enroll in Medicaid at that level, but then also reducing parent eligibility to that level. And in doing so, especially during that first open enrollment period back in 2013, we saw a transition of these parents to the health insurance marketplace. And unfortunately, some probably ended up uninsured because of that awkward transition of coverage. So now fast forward to kind of where we're at here. We have various options, as I mentioned, in coverage. Medicaid being one of them, but this is kind of the direction that we start with. We look at job insurance because if someone is eligible for employer-sponsored coverage, they may not qualify for the marketplace down the road. We look at Medicare, and so for this group of 45 to 60-year-olds who are near retirement, they most likely would not qualify for Medicare unless they were also experiencing a determined disability, and that would have been something that we looked at. And then we would look at Medicaid based on their income. And so for our population that we're talking about, we'd be looking at under 100% of the federal poverty level. So for one individual, about $12,000 to $13,000. And then for marketplace, if they are above 100% of the federal poverty level and in that range all the way up to 400% of the federal poverty level, they would qualify for financial assistance to help lower the cost of insurance through the marketplace. And this is kind of where I thought it was interesting thinking about the research. The populations that they studied, they saw a potential increase in costs in their healthcare expenses, even though these were in states that expanded their Medicaid. And the reason I was telling you numbers in terms of how many or how much people can make to qualify for whether it's Medicaid in Wisconsin, whether it's Medicaid in an expanded state, and for marketplace tax credits, I think folks that are in that 45 to 60 range and are still working, maybe even still working part-time, or are deciding whether to stop working, or are potentially considering starting to collect, especially when they're a little older, Social Security benefits, they're going to fall into a really interesting place when it comes to their income as a household. And even if Wisconsin were to have expanded its Medicaid, I think a lot of those folks would still be over Medicaid eligibility with what, at least anecdotally, we've seen in those age groups here in Wisconsin. Because a lot of times they're just over Medicaid eligibility, even in that expanded level, which brings us back to, and here's some numbers to kind of get an assessment, at least here in Wisconsin, what people could be making to qualify for Medicaid. But what I think is really interesting, and sorry, I'm switching over because the study and the questions have gotten me really intrigued. But I think what we're comparing is someone who may have been eligible for Medicaid, and if they're in an expanded Medicaid state, maybe they would qualify, but maybe they're just over, and we're actually looking at health insurance coverage in the healthcare.gov marketplace. And if that's the case, if they're not looking at the right plans for them, because there's 4 types of plans in the marketplace. We have bronze, silver, gold, and platinum. Bronze plans are going to be the most affordable, but they're going to have the most significant cost sharing. And that's the work that our navigators do to help people understand what those options mean for them, so that at the end of the day, they're choosing something that they can afford each month in terms of premiums, but also can afford when they need to go to the doctor. Because we know that if people have these high deductibles, they're not going to go. They're going to avoid accessing care. And we've seen it. We've seen people that say, yep, I'm really comfortable going with the cheapest plan available to me. But then the next year, when we see them at open enrollment time, they're like, yeah, I never used my health care. And there's preventative free access to care embedded even in those high deductible plans. But once again, we don't see people using even those services because they're worried about what are those other cost shares that are going to come up unexpectedly. And unfortunately, in our healthcare system, the way costs are shared, things are changing, but it's very slow. People don't know how much things are going to cost. And because of that, they're going to avoid using that care. So I want to be conscious of time, and I know we're close to being done. One last thing that I wanted to mention is right now we're in a special moment because during the pandemic, Medicaid was expanded. Not expanded in terms of eligibility, but people didn't need to renew, and terminations were paused during the length of the pandemic. And that's coming to an end on March 31st, 2023. And people will need to renew their Medicaid coverage for the first time in 3 years between May 2023 and May 2024. These are just some resources of where you can go for help for your local navigators here in Wisconsin, or resources that might help you find navigators in the state near you. And these are just some of my final thoughts, but I want to make sure we have time for questions.
Thanks, Caroline. Much appreciated. And thanks to all the presenters today. We're short on time, so we're not going to have much in the way of Q&A. However, I do want to pose a question to the researchers, one that was submitted around, and then we'll end our Q&A and conclude our webinar. But it's around this idea of struggling with medical bills. That was mentioned earlier in the research portion of the presentation. So I was hoping you all might be able to talk quickly about if there's a specific definition to struggling with medical bills as it was found, or as you mentioned, and also how that would relate to its impact on medical bankruptcy. There were some things in the Q&A around that. So if you all have any thoughts on that, I'll pose that to either of our researchers.
Yeah, sure. I'll take it. So we, in terms of medical bills, these are all just self-reported, so people can interpret the question as they want. The SHED survey changed over time in how they report out-of-pocket medical expenses. So we try to group them as best as possible, but it's all how people interpret it. And so, you know, what we're really thinking is kind of the comprehensiveness of Medicaid might be more protective of these out-of-pocket medical expenses than marketplace coverage or private insurance, although we don't know exactly. We haven't kind of been able to link the exact, Medicaid cost sharing requirements to these individuals yet. And that might be a potential source to kind of solve some of these problems, is looking at kind of the Medicaid rules in the different states to understand how that affects them. There is a lot of interest in medical debt and medical bankruptcy. And the way I think of it is very similar to kind of the work I do on non-financial products like payday lending. And so, people may have medical debt or unpaid medical bills, and that's kind of also similar to their other unpaid expenses, and that may just tip them over into bankruptcy. Although there are some, just like the literature on payday lending, there's broad disagreements, there's mixed findings in the literature, and we know there's medical debt in a lot of bankruptcies, and whether that's the cause of the bankruptcy or not is really to get it. And we know that's still continuing even with the Affordable Care Act, in part because there are, we didn't eliminate out-of-pocket spending and other costs that people can incur with healthcare. So I hope that answered the question. And
yeah, I think it does. It provides some clarity on the bankruptcy piece, but also that struggling with medical bills is sort of in the eye of the beholder, the person experiencing it, right? So that's very helpful. So yeah, thank you for that, Katie. We don't have any other time for a Q&A today, so I do want to offer our attendees the ability to follow up offline. You can email me directly with any questions, and I can pass those on to our presenters. My email is jonathan.ferguson@wisc.edu. And that will be included in your follow-up email that you'll receive. So that's a possibility there. And on that front, I do want to say before we close that just a reminder, today's webinar was recorded and will be posted on the website later this week. And I just want to thank everybody for their time and wish everybody a great day. Bye-bye, everyone.
Thank you.
Thank you.